Hello everyone, I'm myself Dr. Dipti Kariya. I'm the PhD Physiology and your educator for physiology. Today we'll continue our discussion regarding cardiac arrhythmia, which we have discussed in our first class. So you just can watch the first class of cardiac arrhythmia, and we are continuing our discussion here. In last class, before starting my lecture, I would like to inform you all that you will get all my notes in soft copy and hard copy. To get the soft copy, you have to download the application Vesalius and subscribe for the same to get all soft copies. And for hard copy, you have to get my book that is available on Flipkart as well as Amazon. Okay, link for the Flipkart, Amazon as well as my application that is given in the description box. Along with that, you can join us on our WhatsApp group that is 78638226668. You can ask any query related to book, related to application. You can join us in our WhatsApp group that also we have created. So let us start our today's topic, that is cardiac arrhythmia. In our last class, we have discussed cardiac arrhythmia are divided in three groups. One, that is abnormal sinus rhythm. Second is conduction disturbance, and third, that is ectopic cardiac rhythm. We have discussed these two varieties in our last class. One, that is abnormal sinus rhythm, which is again divided in sinus arrhythmia, sinus tachycardia, sinus bradycardia, and sixth sinus syndrome. And conduction disturbances, they are SA nodal block, AV nodal block, and bundle branch block. And today we'll discuss about ectopic cardiac rhythm. Okay, now ectopic cardiac rhythm here. Ectopic means the focus is not natural. Any irritable focus that is capable of discharging impulses repetitive impulse discharge from any irritable focus that is possible, that is rapid as compared to SA node. Okay, so it will generate its own impulse, and because the rate is rapid than SA node, it may become your pacemaker. Okay, so this rhythm is ectopic because it is not from this normal conducting tissue. Okay, and that if it is once only, that produces ectopic cardiac beat here, sorry, this one. And if it is multiple time discharging, then it produces ectopic cardiac rhythm. Okay, now so this arrhythmia is of two types. Number one is atrial arrhythmia if your ectopic focus is in the atrium, and ventricular arrhythmia if the focus is there in the ventricle. Okay, as I told you, another thing, if it discharges once, then it is extra systole, means only one systole extra. But if the discharge is repeatedly, then it results in cardiac arrhythmia. Okay, now starting with first one, that is extrasystole. What do you mean by extrasystole? That is any premature beat or premature contraction, which is also known as ectopic beat, and that is the contraction of heart prior to the normal beat. You can see here, before the normal beat, there is extra P or extra beat has come. Okay, and what are the causes of ectopic or extrasystole? That may be because of any ectopic foci in the atria or ventricle, and that may be because of local ischemia, some calcified plaque formation, or irritation of either SA node or AV node. Okay, then atrial extrasystole. If the premature beat is originating from the atria, what are the ECG changes you find? One, that is you will be having premature P wave. Okay, or you can say sometimes biphasic peaked P wave, two peaks are there here. Okay, then you will be having short PR interval. Short PR interval. Why short PR interval? If the ectopic focus is from the atria, your P wave is slightly more and PR interval is short. But if the extrasystolic excitation that has taken abnormal pathway to reach to the AV node may be long PR interval. Okay, then QRS and QRS complex in T are normal, you can see here. Okay, cardiac rhythm is shifted and it has got reset. We have long TP interval. Why? Because of this extrasystole, there is compensatory pause, means one beat, next beat that cannot stimulate the cardiac tissue because the cardiac tissues are in the refractory period. Okay, so there is compensatory pause. And what is the significance? This atrial extrasystole may occur normally sometimes, and sometimes patient may or may not be aware of that. Now, it may be clinically found as pulse deficient. Due to premature beat, ventricular filling is not complete. Okay, so what happens that there is you can say that there is heart rate you found, but there is no pulse. So you can say that deficient in the number of radial pulses as compared to contraction of the heart because of incomplete filling of the ventricle. That contraction force cannot be transmitted to the pulse. Okay, that is also known as pulse deficit. Okay, second is if the extrasystole is in the ventricle. Okay, premature beat originating from the ventricle, that is known as ventricular extrasystole. Okay, and this is also known as PVC, premature ventricular contraction. Now what are the ECG changes here when the extrasystole is from ventricle? We have absence of P wave. You can see here no P wave is there. This is T. Okay, you can draw this kind of diagram also. This diagram self drawn diagram. You can also make a practice of making this kind of diagrams. Okay, so abnormal P wave. QRS complex is biphasic. You can say bizarre and prolonged one. Okay, because of the abnormal route of spread of the impulse. Okay, P wave of the next cycle may be buried with the abnormal ventricular complex. Okay, and T wave is always in the opposite direction. You can see here this one. T wave is opposite to the QRS. Okay, and that is followed by pause. Here, compensatory pause. Okay, this is the ECG changes in the ventricular extrasystole. Sometimes this premature ventricular contractions or ventricular extrasystoles, they are present normally also, maybe because of excessive cigarette smoking, lack of sleep, excessive caffeine taken, or emotional irritability may produce this kind of. But if it is associated with clinical features, and if other clinical features and ECG changes of ischemia and infarction are there, then that is to be evaluated. Okay, because otherwise it is converted into lethal ventricular fibrillation. If your PVC falls during the vulnerable period means at the end of the T wave, when it falls, that is the supranormal period. At that time, if any other extrasystole comes, that may convert rhythm into fibrillation. Okay. Now, what is the mechanism of development of cardiac arrhythmia? Two mechanisms. Number one is either ectopic foci for the excitation, and second mechanism is re-entry mechanism. We will discuss first, that is ectopic foci. As we have discussed, SA node is the normal pacemaker of the heart. Okay, but if some abnormal condition, any other part of the heart has started generating impulses, then it is your ectopic focus. Okay, as we have discussed, if it generates impulse once, then it is extrasystole, and if it generates impulses repeatedly, then it results in arrhythmia. Okay, so single discharge results in extrasystole or premature beat, and next beat may be normal. Premature beat may be atrial if the focus is in the atrium or in the AV node or ventricle, anywhere. But if the discharge is repetitive, then it may result in the arrhythmia. Okay, and depending on the rate, rhythm, and site of ectopic focus, this arrhythmia may be paroxysmal tachycardia, atrial flutter, atrial fibrillation, ventricular fibrillation. We will discuss about them. Okay, now second mechanism is re-entry mechanism, which is also known as circus mechanism, which is the commonest cause for tachyarrhythmia. Here what happens, this excitation wave, it re-enters in the circuit, or it enters, wave of excitation repeatedly enters in the closed circuit. Okay, and for that also there are two mechanisms. Number one is transient block in the conduction pathway, that causes retrograde conduction. We will discuss. Second, that is presence of some abnormal extra bundle, like bundle of Kent for the conduction. So starting with first one, transient block of conduction pathway that causes retrograde conduction. What is this and what is the mechanism? Normally what happens when the wave of depolarization, when it or excitation, when it reaches to this ring-like structure, it will go on both the sides of ring. Okay, and it will move like this. It excites on both the sides like this, and it will go this way. Okay, but suppose, as we have discussed, there is transient block for few seconds. Okay, so you can say that if there is a block here, this impulse cannot excite this area, depolarize this area. Why? Because this is the area, it is refractory to the depolarization. Okay, so this is the first thing which has happened to the transient block. Then what happens next is one more thing. What happens afterwards? Here you can see this cannot be depolarized. Now when this impulse, it comes here, and now this block, because it was transient, now it has been relieved. So what happens when this impulse reaches here? Now it can depolarize it. So it produces this kind of continuous depolarization in this circuit, and this is known as your transient block that has produced re-entry or circus movement. Okay, second one, that is, as we have discussed, re-entry because of abnormal circuit bundle of Kant. You can see here, normally impulses they pass from SA node to AV node through internodal tracks, but if there is some other bundle, this is bundle of Kant. So what happens, these impulses they pass from SA node to bundle of Kant to the ventricle, and they, when they reach to AV node, this AV node is not in the refractory period. So what happens, now this impulse they excite AV node, again they go back in this abnormal pathway. Okay, so this is also the mechanism for re-entry. Okay, this way you can see. Now there are certain conditions in which re-entry of the impulse takes place. Number one is if the pathway is long, like if your heart is dilated. What happens, suppose your impulse is moving from SA node here in normal heart, SA node to AV node, then bundle branches like this. Okay, suppose in normal heart this impulse requires your uh, 0.9 second to reach here, not 0.9, it would be more here, 0.9, 0.3, suppose 0.15 seconds to reach here, fine. But if the heart is dilated, instead of 0.15 seconds, the same impulse required 0.22 seconds to reach here. Okay, now what happens when the impulse has reached at 0.22 seconds here, at this point, when it has reached at 0.15 second, this period is refractory. Okay, but here when the impulse reaches here at 0.22 second, it is not refractory, so it will continuously going to stimulate it this way. So when the pathway is long in dilated heart, okay, then this results in re-entry mechanism. Second thing is, if the heart is not dilated but your conduction velocity is reduced, so this impulse requires more time to reach here, and again that results in re-entry. Third is short refractory period, because if some drug is given like epinephrine or any other electrical stimulation, so this impulse they have this impulse when reaches to this area, that is not in refractory period, so there is continuous stimulation, and that results in re-entry. Okay, now, and bundle of Kent, what happens here, that presence of bundle of Kent that produces Wolff Parkinson's White syndrome. What are the ECG changes here? What happens, PR interval decreases because impulses they pass very fast from SA node to AV node, but because it has taken abnormal pathway, QRS complex is prolonged, so that is second change, and therefore PJ interval from P to the J point, that is same, will not be changed. Okay, because decrease PR but increase QRS complex. Okay, now various arrhythmias we will discuss, that is atrial arrhythmia, ventricular arrhythmia, nodal arrhythmia. Atrial arrhythmia are further divided into atrial tachycardia, atrial flutter, atrial fibrillation. Ventricular arrhythmia are again ventricular tachycardia, flutter and fibrillation. Nodal arrhythmia, nodal paroxysmal tachycardia, Wolff Parkinson's White syndrome, and and Ganong Levin syndrome. And fourth one, paroxysmal tachycardia, that is paroxysmal atrial and ventricular tachycardia. We will discuss important one. Number one is atrial arrhythmia, one that is atrial tachycardia. The name itself suggests heart rate increases, otherwise it is normal, originating from SA node and it passes. Okay, atrial to ventricular rate is 1:1, means atrial rate, if it is 100, ventricular rate is also, or 120, ventricular rate is also 120. Okay, and the atrial contractions are regular. And what are the common causes for atrial tachycardia? That is overdosage of alcohol, caffeine, nicotine. Okay, here ECG shows all intervals are short and T wave merges with the P wave of the next cycle. The next is atrial flutter. Here this is this one, discharge impulse rate, that is from atria is 200 to 350. And another important characteristic is some parts of the atria are contracting and other are relaxing. So all the blood will not be pumping from atria to ventricle. Okay, and therefore AV node is not able to transmit all the signals. So you can say that AV atria to ventricular rate, that is 2:1 or 3:1. Okay, and ECG finding, they are like tachycardia, but sometimes second degree of heart block is like changes are present. Then third is atrial fibrillation. Here rate of discharge is again increases 350 to 500. This is in figure C. You can see here this one. Okay, and this again in atrial fibrillation there is irregular oscillation of the impulses, and that produces F wave, fibrillating waves. Okay, and atrial because of this atrial fibrillation, atria cannot pump effective amount of the blood during atrial contraction, but it has not much effect on the cardiac output, because atrial contraction that provides only 20% of filling of ventricle. Okay, otherwise 80% filling takes place during atrial diastole. Okay, so it has not much effect on the cardiac output. Okay, ECG finding, you can see here we don't find P wave. Instead of that, F waves are there. F waves are also known as fibrillating waves, which are high voltage. You can see, sorry, high frequency, low voltage waves. Okay, frequency is high and voltage is low. Okay, and RR and QRS complex, they are irregularly irregular. You can see here. And but when this QRS and T comes, it is normal. Ventricular rhythm is irregular because irregular arrival of the impulses from atrial muscles to the AV node. Okay. Treatment is electroshock that is given, and atrial fibrillation can be converted into normal rhythm by electroshock. Passage of single strong electric current or electric shock. And what is the mechanism here? This electric shock throws entire heart into the stage of refractoriness. Okay, so heart is refractory to each and every impulse for few seconds, and after this refractoriness state, when heart started its rhythm, that may be the normal one. Okay, so this is your treatment for atrial fibrillation. Then ventricular arrhythmia, they are one that is paroxysmal ventricular tachycardia. Here again the same thing. Tachycardia means a rapid and repeated discharge from the ventricle. Okay, this is causes are, if it is from ventricle, that is serious heart disease. It may be because of the drug toxicity. Commonest drug toxicity produces ventricular tachycardia, that is digitalis. Okay, when it is used for the treatment of heart disease. Here it causes generation of irritable foci, and that results in ventricular tachycardia. But that can be treated by the other drug, that is quinidine. And what is the role of quinidine? It increases the refractory period of the heart, and when refractory period of the heart increases, then that irritable focus cannot stimulate the heart, because it is in the refractory period. Now what are the ECG changes in tachycardia? Here wide, bizarre, you can say QRS complex, and P waves are usually not distinguishable. You can see here these are the QRS complexes without P waves. Then comes your this paroxysmal ventricular tachycardia. This we were discussing. They are serious because it does not occur until there is ischemic changes. There is rapid and repeated stimulation of the ventricular muscle, and significance is when because of ventricular tachycardia, cardiac output decreases, and that is life-threatening situation. Okay. Other is ventricular flutter. Here rate of discharge of the impulse increases, and ECG finding we have again flutter. If it is flutter, the rate of discharge impulse discharge, that is 200 to 350 beats per minute. Okay, and we find large oscillations like hairpin curves which are present. Ventricular, then third one, that is ventricular fibrillation. Here what happens, the rate is further increased. The rate is more than same way in atrial fibrillation. The rate of discharge of impulse, that is 350 to 500 per minute. Okay, and what is the cause? For the ventricular fibrillation, there is passage of cardiac impulse with stimulating one point and re-excite the same ventricular muscle over and over. And what are the effects of ventricular fibrillation? Because there is no coordinated contraction of all the muscles, so you can say that cardiac output is reduced. Okay, and after 4 to 5 seconds of the onset of ventricular fibrillation, patients becomes unconscious because lack of blood flow to the brain, and that results in irreversible death of the brain tissues. Okay, fibrillation, that is initiated by various factors, like if the person is having sudden electric shock, okay, and that results in ventricular fibrillation. Ischemia of the heart muscle, especially conducting system, or both, that also produces ventricular fibrillation. As we have discussed, the rate is 350 to 500 beats per minute, and ECG finding here C1. They are irregular, extremely fast, but the potential is small, you can see. And rate, rhythm, and amplitude, they are fluctuated. Fluctuations in the rate, rhythm, and amplitude that is found in ventricular fibrillation. Okay. Treatment is again same, electroshock defibrillation of the ventricle that is advisable here. Strong high voltage AC current that is given for a fraction of second. And what is the mechanism? As we already discussed, all the ventricular muscles, they are going in the state of refractiveness, and after 3 to 5 seconds, when they start generating their own impulse, they may generate at normal rhythm. Okay. In between, cardiopulmonary resuscitation is also given, in which heart is squeezed intermittently by, you can see here in this picture, that heart is squeezed intermittently by hand and then defibrillating the heart later on. Okay, so because of that, small quantity of blood are delivered into the aorta and renewed coronary blood flow develops in this way. Okay, so the intermittent thrust of pressure on the chest wall that is given by the hand along with artificial respiration and defibrillation, and this all three that is known as cardiopulmonary resuscitation. Nodal arrhythmia, that is again divided in nodal paroxysmal tachycardia, which is similar to atrial tachycardia, and this is also known as supraventricular tachycardia. ECG changes, it cannot be distinguishable. Then second nodal arrhythmia, that is Wolff-Parkinson's White syndrome, we have already discussed. Here there is presence of bundle of Kent. So ECG finding, you can see here, PR interval is short but QRS is prolonged, so PJ interval is normal. Okay. Next is Ganong Levin syndrome. Here this is also nodal tachycardia or paroxysmal supraventricular tachycardia. Here you can see depolarization passes from atria to ventricle, but not by the bundle of Kent, by some other pathway. This is Ganong Levin syndrome. But ECG changes here is PR interval is also prolonged. ECG changes are PR interval is short. This one. PR interval is short when you are comparing with the normal one here, not with this one. This you may get confused. So PR interval is short, 1, and QRS is, normal. You can see here. This is normal QRS. Okay. So short PR and normal QRS. So PJ interval is also short here. PJ and PR short, QRS is normal. Fine. So this is all about your cardiac arrhythmia and some ECG changes. Again, if you wish to get all my notes, lecture notes, they are available in soft copy in my application Vesalius. You have to download and subscribe, and hard copy that is available on the Flipkart and Amazon. My book, that is Physiology Notes. You can join us on our WhatsApp group. The number is 7863822668. Okay. Thank you so much. If you like my video, you can like it, you can share with all your friends, and subscribe my channel. Thank you.